Good evening, everybody who has joined. I hope you can all hear me. So the talk today is on, the webinar today is on knee pathologies. So knee examination and common pathologies. Some of the slides which I'll show today has been shown during the hip pathology also, because there is some crossover between hip and knee pathology. And the treatment for the arthritis, the neuromuscular exercises are nearly the same, whether it's hip arthritis or knee arthritis. And there's a lot of slides today, so I'll try to go through. I mean, as before, always I try to keep more pictorial slide rather than text slides, because it's important that we are conveying the message through pictures rather than a lot of text. But there will be some text slides. So we are going to look at anatomy. We're looking at some examination, interesting cases with evidence, and neuromuscular exercises to end with. So the knee joint, there are two joints, two functional joints. There is this is the lower end of the thigh bone or the femur. This is the upper end of the shin bone, the tibia. And this joint is the main femorotibial joint. And there is one more joint, between the kneecap and the front of the femur. The patella is a sesamoid bone, that is a bone within the ligament, the patellar ligament. Now, the patella is given as like a pulley system. Patellofemoral is a pulley system, because we have two muscles which are anti-gravity muscles, the gluteal muscles and the quadriceps. The quadriceps are the muscles in the front of the thigh. They are anti-gravity muscles. That is, if you are squatting, they help you to stand up from the squatted position. Now, that means they have to lift our entire weight. The quadriceps, or the muscle in front of the thigh, is quite long and is quite, it is advantageous to give that power. But the glutes, they are small. Sorry, the glutes are short and stubby and they have good power. But the quadriceps are long and they don't have good power. And to increase their power, that is why we need the kneecap as a pulley system. Sorry about confusing. Now, basically, in the knee joint, there is flexion and extension, but also there is a mild rotation when you keep it completely straight and the knee is locked. So that's why we can stand for long periods without being stressed. Whereas if you just bend it by 5 degrees, you can find that our muscles become very tight quickly. As I explained, that patella is a sesamoid bone, a bone within the tendon, the ligament itself. There are many ligaments, but the four main ligaments are the medial collateral ligament between the femur and the tibia on the inner side, the lateral collateral ligament on the outer side, and there are two ligaments in the center, the cruciate ligaments. They are called cruciate because they are in the form of a cross. There is the anterior cruciate ligament, which gets attached to the front, and the posterior cruciate ligament that gets attached to the back. In addition, there are crescentic carpets made of cartilage, and they are the medial meniscus and the lateral meniscus. The lower end of the thigh bone is round like a ball. There are two round balls. The round ball has to sit on a flat table. The top of the shin bone is flat. To sit on the flat table, nature has provided us with crescentic carpets so that the balls can sit in the center of the carpet. And it is a load bearing, and only the outer part, the peripheral third, there is blood supply to it. So that's why if it is torn and if it is causing a mechanical problem, it will not repair. There is no point in repairing. Taking out is actually not beneficial. Even if it is torn, leaving it alone inside is the best, and I'll show you some evidence to show that. Now, but sometimes it can lock. Now, this is the view of a house where the carpet is torn. Now, in this view, we talk of locking in the knee, and this is just to explain what exactly happens in locking. So if you see that carpet is torn here, and this is the door, sometimes as you open the door, the flap of carpet may flip over. And when it flips over, it can get jammed. The door may get jammed. The flipped over carpet may get jammed between the door and the floor, preventing the door from being opened fully or from being closed fully. And that's exactly, you can say that as locking or pseudo locking of the door. Similarly, it happens in the knee. If the meniscus is damaged and there is a small tear, and can flip over and get jammed between the thigh bone and the shin bone, because the space is limited space is there, and when it gets jammed, the knee can neither be straightened nor bent, flexed or extended, and that's what we call as a locked knee. If it happens repeatedly, then maybe an arthroscopy and removal of that part of the meniscus may be indicated. So this is the articular cartilage. It's made of hyaline cartilage. It is the very smooth surface which glides easily, and the best part is allows gliding and sliding together. You have the muscles. In the front, you have the quadriceps, mainly the vastus lateralis, medialis, vastus intermedius, and rectus femoris. And on the back, we have the hamstring muscles. Then you have the iliotibial tract on the outer side, and on the inner side, some of the hamstrings and the adductor muscles are there. So these are the quite strong muscles around the thigh. I thought I'll just show, because nowadays MRI scans are very frequently done, and because all of you are health professionals, I just thought I'll just show some MRI images just for understanding. So when you see an MRI, you can see two images at the same time. So this is the view from the front, this is the view from the side. And you can see there is a yellow line. This yellow line tells me where this view is, which part of the knee does this knee view is seen. So basically you can see two views, and that way you can understand a three-dimensional image. So I'll show you as the yellow line progresses to the inner side. So this is the inside of the knee, and now we are slowly going to the outside of the knee. So when you come here, you can see the yellow line, you can see the bottom of the thigh bone here, bottom of the thigh bone, and you can see the meniscus. And you can see over here, I said it's a crescentic carpet. So when you cut this right in the center here, you see a wedge in the front and a wedge at the back. And this is the shin bone. Then when you go here, you can see the posterior cruciate ligament right in the center of the knee, and you can see that as a black spot here. A little bit more, and you can see the anterior cruciate coming here, that is over here. The anterior cruciate gets attached to the lateral femoral condyle. Now we are seeing the lateral compartment, this lateral femoral condyle, lateral tibial plateau, and again you can see the meniscus, the lateral meniscus here, cartilage, and you can see the kneecap or the patella over here. So the patella is slightly towards the side, and you can see parts of the fibula we are seeing. And here it's now we can see the lateral collateral ligament, and the fibula is here. So that's different cuts of the knee, and by looking at it, then we can understand this is a normal knee, which shows where the anatomy is, what part is damaged. When you talk of the history, I'm not going to go through all this. You all know this. But as we looked at locking or catching, that's when the loose fragments, or even there is a loose body inside the knee, you can get a locking sensation. You may also get giving way, because again, as we looked at proprioception, some of the ligaments like the anterior cruciate, they all contribute proprioception knowledge to us how the knee is in what position. So if that is lost, then you have giving way. So you're walking, you're playing football, rugby, cutting and turning, suddenly the knee can give way, or you're doing other normal activities. But if we have a good rehab program, you really don't need an ACL reconstruction. We'll come to that in a minute. And when you look physical exam, you want to observe or look, you want to palpate or feel, you want to see the range of motion or move, and you can do strength testing, and other special tests can be performed. So inspection, you want to look from the front, you want to look from the side, from the back, and while the patient is walking. And you want to look while they are sitting, lying down on the couch, and also to see when they are activating their, straightening out their thigh, and to see how the kneecap is moving, whether it is moving in a straight line or whether there is an inverted J, there is a greater pull of the vastus lateralis. You may need to feel both the inside of the knee and the outside of the knee, whether there is tenderness, that is pain on palpation, that is tenderness, shows maybe there is some pathology or problem in underlying where you're palpating. Now here you can see very clearly the left knee is straight, but the right knee has got a varus deformity. That is, the thigh bone comes like this, and then this angles inwards. And here the varus deformity is very clear. You can see on this standing X-ray that there is loss of cartilage on the inner side. You can see again there is a loss of cartilage on the inner side. There is appropriate cartilage on the outside, but there is definitely loss of cartilage on the inside. Then you want to see the range of motion, how much can be bent, how much can be straighten here. So this is in full extension, this is full flexion, and we should be able to get about 130 to 140 degrees of flexion, and extension should be 0 degrees. You don't want to go into recurvatum, but from 0 to 135 to 140. There are some special tests. If there is fluid in the knee, patellar tap test is positive. That is, you can hold your two fingers over the patella. You can squeeze the fluid from the side and you'll be able to push down the patella, and you can see it slide down and hit on the top of the and in the front of the femur, and it can bounce back again. So that is the patellar tap test. If there is patellofemoral arthritis, it can, when the patella, the kneecap, is ground on the front of the femur, that can cause pain or increase pain, and that may show that there is arthritis in the patellofemoral joint. As I said, there is crepitus, and sometimes there is hypermobility. Some patients have an increased predilection for patellar dislocation, may occur in young women, and the patella slips laterally and recurrent dislocations may occur, and that may also increase the chance of arthritis underneath the patella. But again, rehabilitation, building up the medial muscles is what is important here. There are some special tests. Now, as I told you, the cartilage, they are crescentic carpets on either side for the balls to sit in the center. Now, these carpets may be torn out. There may be a meniscal tear. This is one of the tests, but usually nowadays we don't do this test because it is very painful for the patient, because while you manipulate, it may cause more pain if they really have a meniscal tear. You want to allow it to settle, and potentially with, if you give exercises slowly, it is likely to settle without any intervention. This is again an age-old test. If there is a patellar, meniscal problem, you lie the patient prone on the tummy. Then you push down on you can see that the knee is bent to 90 degrees, and you push down onto the tibia so that you're grinding. And if there is a problem with the meniscus, there will be pain as you're doing the flexion rotation. You can do the same thing dynamically. You can ask the patient to stand on one leg and twist to the clockwise and anti-clockwise by about 20 degrees with the knee in flexion. Again, if there is pain, it suggests, again, many of these tests are for historical significance, not really done regularly. The test that is regularly done is to see whether the collateral ligaments are intact or not. So this is the thigh bone on the and the shin bone, and you can see this is the medial collateral ligament, or the ligament on the inside, and this is the lateral collateral ligament, the ligament on the outside. And you can see how it stabilizes the knee. But when the medial collateral ligament is gone, on this side you can see the medial collateral ligament is gone, then there can be a valgus instability. You can see the lower part of the shin bone can be pushed outside because there is no more restriction on the inside. Same way, if the lateral collateral ligament is damaged or gone, there is varus instability. You can push the distal part of the lower leg inwards, so and this gap will exceed. But when you do the stability test, it is important that the knee is flexed to 20 to 30 degrees. You can't keep the knee completely straight, because then you can't test it. Because if you keep the knee completely straight, then what happens is the posterior capsule is stretched and the knee is not going to give way. So there has to be some laxity in the posterior capsule by keeping it at 30 degrees of flexion, and then you need to stress it, push it one way. So here you're pushing, giving it a varus stress, seeing whether it opens out on the outside. Here we are giving a valgus stress, seeing whether it is opening out on the this is the varus test, whereby you're opening out on the outside. Your valgus test, you're seeing whether opening out on the inside. Then you have the anterior cruciate ligament, and these are the tests to test the anterior cruciate ligament: the Latchman's test, the anterior draw, and pivot shift. So this is the side view. You can see the femur, this is the tibia, and this is the anterior cruciate, which goes from the lateral femoral condyle to the front of the tibia, and the posterior cruciate, which goes from the medial femoral condyle to the back of the tibia. So the anterior and posterior is based on where they come and insert onto the tibia. So the anterior cruciate prevents the tibia from going forward, and the posterior cruciate prevents, I apologize, prevents tibia from going backwards. So if there is anterior cruciate ligament is damaged, you can see the thigh bone, sorry, the shin bone will come forward. That is the anterior cruciate, anterior draw test is positive. So you like the patient supine, and then you flex the knee and the hip, and in this position so that the feet is flat. You can slightly rest on the, ask the patient permission, and keep your, your bum or your thigh on the patient's foot so that you're stabilizing the foot and the lower leg, and then you're pulling the lower leg forwards. So at this point, your index should just feel that the hamstrings is not tight. Some patients may have hamstring spasm, and this won't be positive. Now you can see here I'm doing an anterior draw, and you can see how I'm able to pull the knee forward and back. So this is where it shouldn't be coming forward, but you can see how the proximal part of the tibia is moving forward as I come. So this is the anterior draw test. But Lachman is not in 90 degrees of flexion, is only in 10 to 15 degrees of flexion. Now, why we do that? That is more sensitive than the anterior draw test. But that's what we call as the door stopper effect. If you look at it, the lower part of the thigh bone, it is a round, but it's not a perfectly round ball. Here you can see it is a much smoother curve. Here it's a much more sharper curve. So as it goes to the back of the thigh bone, it becomes a much sharper. At this point, yes, it will slide easily over the meniscus, but if you keep it at 90 degrees, because there is a sharper curve and the radius is smaller, it may stop and prevent the knee from moving forward and backwards, even if the ligament is damaged. So because the meniscus acts as a door stopper, it doesn't move. So that's what's called as the door stopper effect. So that is why you keep the knee in 15 degrees flexion. And if the patient is big, what I tend to do is I keep my thigh on the couch and put my hand, because otherwise my hands are small to hold someone's big leg, and someone who's playing rugby, the leg is going to be difficult. I place my right hand on top of the lower end of the tibia, on the femur, stabilize that, and then pull the tibia forward and backward. You can see how I'm pulling the tibia forward and backward, and here the patient has an anterior cruciate ligament injury. The next one is called the pivot shift test. Now the pivot shift test is slightly difficult to explain, because there's something called the iliotibial tract. The iliotibial tract, in full extension, it pushes the knee as an extensor. But after you flex it for 10 to 15 degrees, it becomes a flexor. It tends to bend. The same muscle acts as an extensor and acts as a flexor, depending on the position. It's like where does it cross the axis. In a full extension, the axis is in the front. In slight flexion, the axis goes back. So if you keep it in full extension, and if the anterior cruciate is gone, it is subluxed and will stay on the front. The tibia will sublux and move forward. But as you slowly bend it, suddenly as you go beyond 10 to 15 degrees, suddenly it becomes a flexor, and suddenly you'll see jerkily the upper part of the tibia moves backwards. So you can see here I'm doing the pivot shift test. So you can see as from it straight, it is sublux, and when I bend it, it suddenly moves backward, and that is a pivot shift. Not very clearly seen, but when you actually do it, you can feel that movement coming through. So that's a pivot shift test. So if the ACL is gone, what are the surgical ways of correcting it? Is either in the previously it was a patellar ligament. They would take a little bit of the petal, 1/3 in the middle part of the patellar ligament, and reconstruct the ACL. You can't repair it directly. It can only be reconstructed. Then the biggest thing was hamstring tendons. They took the hamstring tendons and put it into a graft and reconstructed the ACL. And now of increase this thing is the quadriceps tendon. But we need to really think, do we need this operation? Majority of the patients don't need this operation, and to a certain extent I feel we are over prescribing these operations. And I'll show you why I'm saying, and this is how the reconstructed anterior cruciate ligament looks. Yes, when we talk to a patient, it's easy to say your ligament is gone, we need to go and reconstruct the ligament. But lots of patients do well without reconstruction. Actually, I can show you evidence that there is no difference. Yes, if you're an elite, premier football club player, then maybe an operation may be necessary, but otherwise an operation may not be necessary. So this is how the reconstruction is done, where the anterior cruciate ligament is gone and another, the ligament that you have taken, harvested, tendon that you have harvested is placed in that position. Now, this article shows how, the majority of the people who have ACL reconstruction say they're playing sports and they want to get back to sports. But what we know in this meta-analysis, only 55%, only 1 in 2 will actually return to competitive sports. They are not otherwise returning to competitive sports. So then why have this big operation if you're not returning to competitive sports? Then this is very interesting. They said that there is no return to sport whether you reconstruct or not. So maybe if you reconstruct, you will return to sport greater. Not really. People who have had no reconstruction compared to people who have had reconstruction, there is no difference. This meta-analysis show there is no difference. Both of them at the same rate they return to sport. So if that is the case, then why do an operation if it's not going to make any difference? Yes, if there is an elite Premier Club footballer, then there is some argument, but for the common man, there is less argument. The other argument is that you need to do the ACL reconstruction because if you don't do it, the cartilage will wear out quickly. And this is a study, slightly difficult study. Here, what they did is they are looking at the Swedish register. They're looking at people who had the initial ACL reconstruction and subsequently who had a revision ACL reconstruction. And during the period, they found that there is increased degeneration of the joint. So there is, to say that there is less degeneration after the ACL has been reconstructed is also not right. Now, for a general, this is a very good article. I know it's about 10 years old from Malaysia, but it very clearly explains, and it says it is a medical article, but very clear for a patient whether they need an ACL reconstruction or not. And if you read through the article, it is very simple article. It makes it clear whether someone needs. Yes, if you're either an elite athlete or it is possible that you have multiple episodes of giving way and you are in a physical job, either carrying things or a policeman or a fireman, then maybe an ACL reconstruction may be necessary. Now, this is where an ACL reconstruction has been done. You can see there are interferential screws put into the tibia. The ligament is attached between the two. But we all make mistakes. You look at this one, the screw is not even in the bone. The screw is outside the bone. So obviously it is not a useful procedure at all. So it is important that the right operation, if you need, whether the operation needed, if you need an operation, then the right operation needs to be done. Similarly, when you have a posterior cruciate ligament, what we have is the posterior sag. Normally, the knee would come like this. The tibia is actually slightly more prominent than the kneecap. But if there's a posterior cruciate ligament is gone, then the top part of the tibia sags backward and you have a posterior sag. And then the next part of the test is called active quadriceps test. So you have a posterior sag. You hold on to the ankle and ask the patient to straighten the knee, and just it can't directly straighten. The first part that happens is the sag corrects. So like this, there is a sag, it corrects first. As you pull on the quadriceps, the patient is pulling on the quadriceps, it pulls the tibia forward and then only the knee becomes straight. So that is the active quadriceps test, and that's one of the tests to identify whether the posterior cruciate ligament is damaged. There may be damage to the posterolateral corner. There's also a ligament. It's not one single ligament. It may be multiple ligaments. It also involve the PCL. And then you can do the dial test to see whether there is instability in the posterolateral corner. As we said earlier, some patients have a recurrent dislocation of the kneecap. The kneecap can come to the outside. So if you flex the knee to 30 degrees and gently push on the kneecap to push it outwards, the patient will be very apprehensive and will quite likely prevent you from doing that. So that's called the patellar apprehension test. Now, this is synovial chondromatosis, where it is like a small type of tumor. What happens is the synovial membrane starts making cartilage, small pieces of cartilage, and puts it into the knee. So there is likely to be, locking, multiple locking episodes. And here, yes, surgery is required because you have to take away the loose bodies and maybe even take away the synovium, or consider medications to damage the synovium so that it stops producing these loose bodies. Some people, it runs in some people. It is a genetic defect. Yeah. Here is osteoarthritis. You can see on this loss of cartilage. But sometimes are we over prescribing a total knee replacement? This is what is a total knee replacement. You can see the lower part of the thigh. There is a metallic piece. There is a plastic in the center. Now, also meniscal tear. Meniscal tear is, as we said, we looked at the cartilage in the center, crescentic carpets, holding the ball onto the flat table. So when there is tear, now I've shown, this is another MRI scan. This is very interesting where there is a bucket handle tear. I told you it's a crescentic carpet, so there is a wedge in the front and the wedge at the back. So this slice, you can see there is the anterior cruciate ligament. This slice, you can see the posterior cruciate ligament. On this side, this is the medial meniscus. You can see the wedge in the front and the wedge at the back. So that is okay, but there is some fluid in the knee. But if you see this slide, what you can see is this is the lower end of the femur. There are two wedges, but there is a double wedge here. There is no wedge at the back. So this is a bucket handle tear where the wedge from the back has completely detached and come to the front. So that's like a bucket handle falling onto one side. So from the back, the meniscus, the posterior horn of the meniscus has flipped over, and you can see there is double meniscus there, and this is a bucket handle tear of the medial meniscus. Sorry, the lateral meniscus. Now, previously we used to do arthroscopic partial meniscectomy. So this is a view through the arthroscope. You can see the edge of the meniscus and there is a tear. It looks logical that if there is such a tear, you go and take it out. So you go and trim it and you leave a smooth surface. But now this is not recommended at all. Actually, it causes more harm. And you can see how we started with, there is a small tear in the cartilage and that has been resected and it's smooth now. But the first result came in 2003, about nearly 22 years or 23 years ago. This was a very interesting study. What they did is they divided 180 patients into three groups. So one of the groups where they had a placebo or a sham procedure. So some patients underwent just washout of the knee. Other one-third of the patients went into true arthroscopy. One-third of the patients went through a sham procedure. They got ethics approval to do a sham procedure. That is, patients were taken to the theater. They had small cuts on the skin, but actually nothing was done into the knee. And they compared these three groups. So it's one of the very few where placebo surgery was being practiced. And they found that there was no difference between the three groups at all. So whether you had a sham surgery or a placebo, whether you had real arthroscopy or just washout, there was no difference. Then the next trial came out in 2008, and that's also very interesting. They randomized two groups. One group got surgery and the other group got the other group got physical therapy and medical therapy. Again, at 2 years, there was no difference between the two groups. Again, this third such article came in 2013, where there was without osteoarthritis, there was no OA at all. They just had a medial meniscal tear, and again they were divided into groups, and there was no difference than those of sham surgical procedure. So this was again second time a sham procedure. Now, here they found in fidelity, in the Finnish study, they found that there was actually, if you do it, do an arthroscopy, the chance of arthritis increases. And the chance of needing a knee replacement also increases. Now, look at this patient. He had a knee arthroscopy for arthritis, and then he had a knee replacement. Unfortunately, that got infected. So the knee replacement had to be taken out. He had a spacer, and then he had a revision. Maybe in the first place, he didn't need the knee replacement at all. And here, even after all this, he still continued to experience severe pain in his knee. And then it was found that the pain in the knee was coming from the back and not from the knee at all. If you see here, he's got severe degenerative scoliosis and compression of the nerves that are coming from the back. So it is like the light bulb. So you can see how there is compression of the nerves as they are exiting the spinal canal. So you see a light bulb is not working. Your immediate reaction is to go and change the light bulb, just like how they did a total knee replacement. After you change the light bulb, it is still not working. That's when the penny drops. It may not be the light, it may be the wire that is at the fuse box there is a problem. Then you correct that and the light then works. So that's exactly what happened. In a light bulb, maybe it's only a couple of quid, but doing a knee replacement for radiculopathy in the back is not right at all, because it's unlike a shirt or you can't. If I buy a shirt from Marks and Spencer's, I can go and return it the next day, but I can't go to the hospital and say, take my knee back, I want my original knee. That is not possible. So we need to be very careful before we consider knee replacement. This another interesting study. I know it's slightly old. The study is from Scotland. They looked at patients who were having arthroscopy, and they found that there was severe variation. Some parts of Scotland has very low rate of arthroscopy, 80 per 100,000. Some parts of Scotland very high rate of arthroscopy, 230 per 100,000. So nearly triple of this. The only difference they found is not that the demographics of the population were the same. But then why were there so much of difference? They found that hospitals which had more knee surgeons had more operations than hospitals which had less knee surgeons. So it's not the problem in the patient, it is how the energy or the dynamics of the surgeon who's doing the operation. And unfortunately, people with highest rate of arthroscopy had the highest rate of conversion to knee arthroplasty. So after an arthroscopy, there is increased arthritis. It causes more damage, and you will have a knee replacement surgery. So that is why arthroscopy is done very rarely. But again, I think it should decrease it further. We published this article, maybe I think a year ago. This is a lady, sad story. She had not fit. She underwent a total knee replacement. So you can see her, this is the preoperative x-rays. There is some arthritis, not significant, but she was not given any prehab, not given any exercises. They decided to do a total knee replacement. You can see the implant on the lower end of the femur, implant on the top end of the tibia, and a plastic spacer, an implant on the patella. But unfortunately, she got infected. When she got infected, we had to take off, it was so bad, we had to take off the implant. And then we filled that area with bone cement with antibiotics. That is one of the ways we try to control the infection. So we filled it with bone cement, but again we couldn't control the infection, that finally we had to amputate her leg. She's an elderly lady. We had to amputate her leg. You would think it will end with the amputation, but that was not the case. She died 3 months after the amputation. So basically she was surviving. Yes, she had a bit of arthritis, but we do a total knee replacement, it gets infected, and then afterwards she has an amputation and then passes away. I do agree it's not very common. 1 in 4,000 knee replacements will result in an amputation. It is a very small figure, but it is a figure. Tell the person who had the amputation, well, don't worry, the 3,999 are okay, only you have an amputation. He or she is not going to be satisfied with that. Now, activity is very important. Now, this is people running on a marathon. You can see they are keeping very active. Now, when you look at me, I'm quite pudgy, and you'll say, well, you're not actually being active, George. You are like this. Now, why I put up the marathon, it's like this. When an older adult goes for a total knee replacement, it's like a young man running a marathon. No, I can't just put my shoes and socks, shoes and shorts, and then run a marathon. I need to train for it. I may need to train for it for 6 months or more before I can actually run a marathon. Same way, for an older adult to have a total knee replacement, he needs that training, without which he can't just one day go and have an operation, because that is when complications rise. So yes, some of you may tease me, I'm not running, but I do run. Maybe my motion as I move forward is called rolling, but I do that. And if you don't, I've got some documentary evidence here of me running. This is in front of our house, and you can see me running on this side of the road. There are others running on the other side of the road, and you can see as I come closer, you can be confirmed that it is me who's running. So there is activity. We all need to be active. We all need to keep our muscles strong. So patients who are on the waiting list need to be active. Otherwise, and that is how we can decrease the complications and also decrease the need for surgical intervention. I don't know whether I put up this slide last time. This is Eliza Chakravarti. This is the work that she did in Stamford. And what she did was they took about 1,000 patients who half were runners, half were not runners. And they looked, we think that by running actually you're causing more arthritis, but that is not the case. Over a period of, she followed up these patients for nearly 21 years. And they found that actually the amount of the people who have arthritis and pain is among the non-runners. The runners had less amount of arthritis in the knee and the hip, whereas the non-runners had more. In addition to that, what is very interesting is the survival. The non-runners, community controls, were dying more frequently than the runners. They were all over 50, so they were in the age where they may die. But the runners lived longer than the non-runners. So you have less arthritis, even though you're impacting the knee repeatedly, and you live longer. Now, this is a knee replacement, a vector of a knee replacement. Now, we think knee replacement is easy, but it's not. You look at the Australian registry, they reported their complication rate. And sometimes it is important that we tell our patients. In a total hip replacement, the major complications are 10%, minor complications 34, total number overall complications 39.7. In a total knee replacement, major complications 14%, minor 46%, overall 53%. More than 1 in 2 have some form of complication in a total knee replacement. 1 in 5 patients after a total knee are dissatisfied with the operation. On average, 1 in 10 patients following a hip replacement are dissatisfied. And this is a sad case. Again, we had reported on it a few years ago. A lady, she had knee pain. She had a fall and she had knee pain. She went and saw, she lives not far away from where I'm in Liverpool. She lives not far away. She went and saw a surgeon, and he said, well, you need a knee replacement. Actually, she didn't need a knee replacement at all. You can see she's got pristine knees. This is a weight-bearing X-ray. You can see there is good cartilage on the inside, good cartilage on the outside. On the side view also there is good cartilage. But the surgeon said, you need a knee operation. What does she know? She just accepted that. So she underwent a knee replacement. But did her pain get better? No, because that was not the cause of the pain. There are many reasons for the pain. So it is important that we are understanding what is the real cause of the pain. Just because they are complaining of knee pain, we shouldn't rush into doing an operation. There's something on the chat. I'm just going to look at it. Oh, there's a question. Okay, we'll come to that later. Sorry. And as we said earlier, by doing arthroscopy, you're increasing the level of arthritis in the knee. So it is important that our arthroscopy is not done. There's a threefold increase in the risk of future knee replacement surgery if you just put a telescope into the knee. There's something called the Donabedian effect. Donabedian effect he was in the early part of the 20th century. Now, if there is a good thing, you can have a little bit of the good thing. But if you have too much of the good thing, there is a point where there is reversal and you're not going to get that benefit. So that's how, even knee arthroscopies, in the early 2001 to 2010, we were doing a lot of knee arthroscopies which are of no benefit whatsoever and actually might have caused more harm to patients. Here is another patient. He had a previous knee ligament reconstruction. That's why you see the screw. And then he had this arthritis. You can see there is arthritis there. Then he undergoes a knee replacement. He's a 60-year-old gentleman. He has a knee replacement. It initially goes well. Then afterwards it gets infected. He does a bone scan, and you can see the bone scan is lit up, showing that there is increased activity in the knee. That knee is taken out and a new knee has been replaced. So multiple procedures. In the first place, could he have done without the knee replacement? Are we giving the adequate exercise therapy? I know most of, nearly all of you are not surgeons. All of you are maybe, non surgeons, but you have the greatest role. I want you to work hard and help these patients, because when you don't help, they land up in the hospital and they maybe not needed surgical interventions are being done. So we need to inspire. You're the best people to inspire the patients to do. Now, unfortunately, medical science don't like revealing all this. This is Codman. Codman was in Massachusetts General Hospital. So he identified that, at that time when he was in Massachusetts, they were doing prophylactic appendectomy. That is, the appendix were being removed. So anyone who had an appendix, they would say, come and you may get inflamed, come and remove that. But then if you do prophylactic appendix, when you have an inflammation and or an infection, to take the appendix off is maybe good. Nowadays, we don't even do that. We try to control it with antibiotics rather than remove the appendix. But during his time, they were doing a prophylactic. Because they were charging people for the appendectomy. And there were complications. So he is the one who started the audit process, and we should measure our outcomes. So in just to criticize the hospital administration, he put up this cartoon of the golden goose ostrich. So basically, the managers of the hospital were just looking for a golden goose to lay eggs. The appendectomy is the laying the eggs, and they were burying their head, not looking at the complications. What happened? He was dismissed from the hospital and told to go out of the hospital. So even if you raise a genuine problem, if you whistle blow, you're likely to be penalized for it. There's an interesting book. I don't know whether any one of you have managed to read it, by Ian Harris. He's a professor in Australia. And he wrote a very interesting book, Surgery, the Ultimate Placebo. And he cuts through the evidence of lots of, he starts by bloodletting and how in the current century we do lots of surgeries, including arthroscopy, which are needless. The most important thing is that the strength of the knee weakens, and when we get back the strength, much of the knee pain goes away. I've told you this before, it's like the car tire. The car tire needs 40 pounds per square inch. If you pump the air up to 40 pounds per square inch, the shock absorber deal does well. But if you don't put 40 and only put 20 pounds per square inch, the car will wobble as we drive, and when it wobbles, there is going to be damage to the shock absorber. Same way in the knee. If the muscles in the knee are weak, there is going to be increased wobbliness in the knee joint, and there will be arthritis and pain. Whereas if the muscles around the knee are strong, then there is no wobbliness, it moves correctly, and there is less likely chance of arthritis. We call wear and tear, but really, is it wear and tear inside the body? Our bodies have life. Last summer, I went cycling. I fell and cut my hand. I came home, washed it, left it alone. Within 3 weeks, it had healed completely. Around that same time, as I was reversing my car through my driveway, the fender caught the pillar at the end of the driveway and there was a scratch. Just like my arm, I washed the car and left it. But it's now 1 year and still not repaired itself. Yes, in this object, in the car, it is unlikely to repair because it doesn't have life, whereas my arm has life. So in inanimate objects that don't have life, there's only a one-way process, wear and degeneration. Whereas in objects that have life, there is a two-way process. There is degeneration, but there is also regeneration. There is building up, a repair process. So that is why it is important. So in the human body, as there is degeneration, there is regeneration. But so it's the wear and tear should be out, and we should be calling it wear and repair inside the body. We shouldn't be calling it wear and tear arthritis. And healthy loading is good. As I showed you, Eliza Chakravarti's running is good because yes, there is some wear and tear or wear and repair, and there is repair in the same process. But yes, too much of wear is also bad. Like if you do a heavy load or you do ultra marathons, every 3 weeks or 2 weeks, then it is beyond what the body can cope and there's likely to be damage. Equally, not doing any activity, sitting idle, watching TV, there is no ability to repair, because unless you move, unless you make the muscle strong, you're not going to have the repair process. Now, if you're an animal lover, I would like you to close your eyes. I've shown this slide before. If you're an animal lover, close your eyes and close your ears, because they did some good work in Canada, Herzog and group. So they took these New Zealand white rabbits and injected the half the rabbits with Botox, the same Botox that we inject into our faces. And so there were the controls. The controls didn't have the Botox. The other group of rabbits had the Botox into their thigh. And they compared. 1 month, all the rabbits were sacrificed and they looked at the cartilage. The one that didn't have the Botox had good cartilage cells, and even in macroscopically you can see it's a nice smooth. Whereas the ones which had the Botox and there was weakness of the muscle, the cartilage cells had decreased, and also the end of the bone, end of the cartilage was fibrillated. And macroscopically, you can see how there was redness, within the month as soon as there was weakness of the bone. So it's a weakness that, causes. So we need normal articular cartilage, and that comes, it is, as I said, smooth, moves well, and distributes weight, but we need the muscles to be strong. There are different stages of osteoarthritis. We call it the Kellgren-Lawrence scale. So this is early. Whether there is, we don't know. The next stage is mild. Grade 3 is moderate, severe. So it is only maybe in severe cases we really need to do arthroplasty. Even then, you need to give a trial of exercises. Now, yes, we know scientifically that the cartilage doesn't repair, but arthritis is not just the cartilage, it is a whole joint. Now, just because you don't have cartilage doesn't mean that you can't do. Look at these runners. They don't have legs, but they're running better than all of us can run together. Now, that is, and even in spite of not having legs. So yes, just because the cartilage is lost doesn't really mean we can't make it better, because the human body has ability to repair itself. And this is the work by Professor Sorensku from Denmark. He started the GLAD, or the Good Life with Osteoarthritis, in Denmark. Now, this is an article on knee replacements, and you can see last time I showed you about hip replacements. And 100 adults with total knee replacement, they were given 50 and 50 group, and one non-surgical group. In the non-surgical group, 31 or 62% did not need a total knee replacement. They were all listed for surgery, but they were then, after listing for surgery, they were divided into two groups, and the group that did not have surgery, 31 did not need a knee replacement for up to 2 years. So it is a good way we can treat them. Then this is another study which again shows the amount of medications taken by the patients. So 52% with hip and knee arthritis participant exercise and education program decreased their use of painkillers, and 18% were able to stop their painkillers altogether. So this is the GLAD program, Good Life with Osteoarthritis, and they do the neuromuscular exercises. That's now being followed in Australia, also in Canada, lots of centers in Canada for the GLAD program. Now, the neuromuscular exercises follows the sixth sense, or the sixth senses proprioception. We only know sight, smell, touch, hearing, and taste, but there is another sensation called the proprioception. As we are walking, when my left foot lands on the ground, the left foot sends a million impulses to the brain to tell how my left foot landed. And based on that, my brain gives the right foot the information to land for the next step. So that is proprioception, like the internal. In proprioception, you have the pressure, you have the position, you have the pace. So as we are walking, we are measuring, I know, not consciously, unconsciously, we are measuring the pressure that our joints are putting through, the position of the joint, is there any instability, and if we are moving the joint, it also measures the pace at which we are moving. Are we bending? How quickly are we bending? How quickly are we moving forward? So that's all the three are being measured regularly. Now, we also gain this, stability as a child. This is just an article to say. So as a baby, when we crawl, we stand, fall, then we are gaining that proprioception. But over a period of time, as we become older, we lose that proprioception and then we tend to have falls. Now, that again happens with arthritis. So the first, and then when they exercise, they have pain. So it is important that we are giving them the neuromuscular exercises. When they do the neuromuscular exercises, we stabilize the knee. And once we stabilize the knee, they are able to exercise because it doesn't cause pain. Now, recently in October 25, there was a question raised by Alicia Kearns. She's a Conservative MP for Rutland and Stamford. She asked in the Parliament how many patients are waiting for orthopedic operations, including knee replacements. And it was answered by Karen Smith, who is a Minister of State for Health. And she said there were 866,426 patients. But really, do all of these patients require surgery? Why are we not giving them an exercise program? And if you look at all recommendations, this is the recommendation by I think this is the American College. They recommend exercises. Sorry, this is the systematic review. And there are 156 methods of treatment, but most of the methods are arthritis. This is the American College of Rheumatologists. They recommend exercise for osteoarthritis. This is the ORC guidance. And again, they recommend exercise for arthritis. This is our own UK-based NICE, which says osteoarthritis in over 16s. The treatment is exercise and weight management. That's what they are focused. That's in 22. They said this about non-pharmacological management. It was a nice pictorial was there in the BMJ, which talks about exercise and weight management. But are we really doing the exercise? This was the work that we did in Liverpool, and these are some of my medical students. And what we found that we were not giving adequate exercise and physiotherapy. This graph tells us. So the blue is before the surgery. So before the surgery, people are rating the exercise therapy as poor. Whereas after the surgery, they are rating the exercise therapy as excellent. So, we are not doing, if we can deliver that post-operatively, why can't we do that pre-operatively? Again, physiotherapy, you can see before the surgery, they are rating it as poor, but after the surgery, they are rating it as excellent. We need to give exercise before as much as we are giving, after the surgery. Unfortunately, Dorothy, when she's listed for surgery, she's still at home knitting away and not exercising. We want Dorothy to get up and exercise. Only then. This is a story of a lady who had osteoarthritis in the knee, with one of my patients. She had gone to a surgeon in a hospital, and she had shown this knee and said that she had knee pain. The surgeon said, you need a knee replacement, and she was listed for surgery. She was not sure. She came and saw us, and this was the patellar skyline view of the patella, and this is the lateral view of the left and the right. So the main arthritis was in the front view. You can see on the left knee, there's decreased joint space. We gave her our neuromuscular exercises, and you can see her own statement now. Just give me a few seconds, it'll start. Susan, thank you for coming to our clinic today. Sorry, 1 minute. I think you may not be listening to the sound. I apologize. 1 minute. I will just stop this. Oh. I have to share sound. I'm so sorry. You're not hearing, I presume. Yeah. Are you able to see and Susan, thank you for coming to our clinic today. And I'm so grateful to hear that, so happy to hear that you've done the exercises and you find that your knee is better. So just so that others who can listen to this video can be inspired, just tell us your story. When did your knee pain start, Susan?
About 12 months ago. Yes.
And which knee was it? Both the knees or one knee?
My left knee. My left knee is good.
And then what happened after that?
Well, I went to the specialist, saw the specialist, and I was...
That was in the hospital?
Yes. And I was diagnosed with severe arthritic pain from my knee, arthritic knee. And that's where the pain was coming from.
And what did they offer you?
Well, they did the x-rays and they offered me surgery. Because they said it was at the stage where it needed to be operated on and I could have a new knee.
So they were offering you a knee replacement?
That's right, a knee replacement. Yeah.
And after that, you contacted us and we gave you the neuromuscular exercises for the knee.
Right.
And I understand you've been doing those exercises regularly. How do you feel now after having done those exercises for 3 months?
I have been doing them now for 3 months, twice. I've been doing them for 6 months. And in the first 3 months, I was very, very impressed because I could control the pain in my knee. I was walking and I was doing all the ordinary things that I could do, that I would love to do, and I was fairly pain-free. Just occasionally do I take paracetamol. And so I'm thrilled to bits that I'm really doing the exercises, taking a little paracetamol, and I'm managing without any pain.
Good, good. So are you now going ahead with the operation or what have you decided about the operation?
Well, I've seen the specialist since and they've offered to put me on the waiting list. But under the circumstances, I've decided to carry on the way I am, doing the exercises, and he will review me regularly in case I need to change my mind and have a knee replacement. But at this present moment in time, I'm going to continue with the exercises, control the pain in that way, which is doing, it's wonderful, really wonderful. It is doing that after the pain that I've had. And so I intend to carry on in that direction and see how things are.
Sure. So now, so you have seen both me and you've also seen another specialist in the hospital.
Yes.
So that's, and the specialist in the hospital was a person who initially offered you a knee replacement, then subsequently you saw me. And now with the hospital, you have said that you want to, you're not going ahead with the knee replacement currently. What would be your advice for others who have arthritis in their knee? Should they be trying exercise or what is your advice?
Well, if I was in their situation, with a painful knee because of arthritis, I would advise them to get the knee pain book, exercise book, and do the exercises, but you have to do them regularly. I do them every morning except one. I do them 6 days a week, and it takes from getting out of my bed to finishing the exercises 30 minutes. So I do dedicate myself to doing the exercises, and believe you me, this is the truth, you can control the pain by doing that.
Thank you so much. That will be so inspiring to the other patients because everyone is very scared and worried. When they have arthritis, they think they shouldn't move, and actually they feel that if they move, it will increase their pain and cause more harm. But there is no evidence that it actually causes more harm. The only evidence, research evidence, is it actually makes it better. And even if you need an operation in the end, because you've exercised, your muscles are stronger, the results of surgery are far better if you have done exercise before than if you have not done exercise. So thank you so much, Susan, for coming and giving this testimony. And it is going to inspire a lot of patients, and I'm grateful for your time and effort. Thank you so much.
That's fine. Thank you very much. Thank you very much.
Goodbye.
Goodbye.
So you can see how neuromuscular exercise, this is another case we reported, this was published, not this lady, another person who was not listed for surgery, but we gave him the ARISE program. What we know of the 10-year plan for the NHS is by Professor Lord Darcy. We are clear that we have to move away from the illness model to where there's hospitals. Where we need is a wellness model where there are exercise therapists in the gym, less of operations. This is a book that I've written, Help for Knee Pain, like how they help for hip pain. And this is what we go through the ARISE program. Awareness as a proprioceptive exercises, resistance where resistance and build up the strength. Individual, it can be individualized to each patient, and you have to increase the core stability and some essential exercises like tiptoeing and sitting sitting up and down. This is how you do the proprioceptive exercises, the awareness exercises, whereby you're doing small lunges and squats while you lower your body down on the left, the right leg slides on the floor. So the right leg is carrying information to the brain on the position, same way the left, and you're trying to you're keeping all the knees steady as much as possible. And that is how you do the sliders. We also have an app. Now you can see how the app works. So you can see me on the left, and the instructor in the app is doing those exercises. It is constantly guiding you, telling you that you're not standing straight, you're following, and it is GDPR compliant because it is not videoing you, it is converting you into a series of dots, and you're following that. And whatever exercises, so we have put all our exercises on this app, and we can so if you're interested, or any of your patients interested and want to use the app, obviously there is a small cost to it, you can approach us. So these are all the exercises we have put onto it. So it's for resisted knee flexion, resisted knee extension, knee bends, sit to stands. And what we are hoping is we need some comparison, whether the endurance testing, and we feel this is some evidence on it. So you should have a 5 kilogram weight on the knee. And if you start off with, say, 50 seconds, you can keep it straight. If slowly increase, so if you can gamify the exercises, and once they can do it for 2.5 minutes or 150 seconds, then you can stop it. So that's how you have to improve the exercises. Thank you so much, and I'll stop the share.